Good evening, everyone. Welcome to the third presentation of the basic modules in infectious disease. I'm Dr. Alia Salim, clinical pharmacist, infectious disease forum member of FCPI. Today's topic is clinical microbiology of gram-positive bacteria, covering both Streptococcus and Enterococcus series. This is organized by Federation of Clinical Pharmacists of India and ID Forum, ID Infectious Disease Forum of FCPI. So before we begin, I would like to quickly go through a couple of things. Participants, you can post your questions in the comment box below the video thumbnail in the website, FCPI website. Second thing, the feedback form will be made available in the comment box below the video thumbnail in the comment box. And certificates will be issued within 7 days after you submit the feedback form. And from tomorrow, all the sessions will be made available in the website. In case if you have any doubt, please feel free to reach us out at the mail in the website. So without any further delay, I would like to welcome our presenter, Dr. Grace Mary John, BCI BP, PharmD, ID Forum member of FCPI. Over to you, ma'am.
Thank you, Alia. So in continuation to our previous talk, where we started off with Staphylococci, the clinical microbiology, the basics of clinical microbiology for gram-positive bacteria. Today, we will be going towards Streptococci and Enterococci. I have no disclosures. I have no commercial interests for this presentation. And the learning objectives is to make sure that we know what the basic microbiology of these organisms are that are causing so many diseases in humans, and very needed for our clinical practice to know the basics of these organisms, to see how we treat them, what to be careful of, what is a clinical spectrum and all that. So going back to the question, if those who are seeing this, if you would remember, this is the same question that I had the last presentation. So I will go through this again. A 45-year-old man with uncontrolled diabetes is coming to ER with symptoms of fever and cough with expectoration. The patient is hypertensive, he's having tachycardia, X-ray shows consolidation in the right lung. The initial culture was drawn and the gram stain, the sputum culture gram stain shows gram-positive cocci in pairs. What could possibly be the organism? So these are the options. I would like you to take a moment and try and see what this organism is. So when you get a culture, it is important that you understand what it is the basic morphological differences between various organisms. So here is a gram-positive cocci in pairs. So the answer to this one is Streptococcus. Now coming to Streptococcus, last time we did talk about the classification based on morphology. Just to brush up what we spoke about, gram-positive bacteria can be classified based on the morphology into cocci, which are round-shaped, and bacilli, which are rod-shaped. And most of the organisms, at least the most important organism that we deal with, comes under the cocci group. So last time we talked about Staphylococci, and this time we'll talk about strep and entero. So again, in gram-positive cocci, once you know it's a gram-positive cocci, you do a catalase test, which is nothing but to see if the hydrogen peroxide or the free radicals that are being produced, whether the organism is able to lyse that. So if catalase is positive, straight away to Staphylococcus, and where again, based on the coagulase, you again classify your Staphylococci. And now we are going to talk about those who are not able to do this, those organisms that are not able to lyse this hydrogen peroxide, which is the Streptococci. Now, Streptococcus, the Classifications, there are two major classifications. One is based on the capacity of the hemolysis, and the other is based on something called the Landsfield classification. So the first classification is based on the hemolysis, which is the alpha. Alpha means it partially, lyses the blood. In the culture that you have at hand, if this organism is growing, it causes partial hemolysis, and the organisms that comes under this are Streptococcus pneumoniae and Viridans group Streptococci. And the next one is beta. Beta means it completely lyses, that is complete hemolysis in the plate, in the culture plate. And the two major organisms that we see here are group A Streptococci, which is Streptococcus pyogenes, and group B, which is Streptococcus agalactiaceae. Now, the third one is the group of organisms, the Streptococci, that does not cause any kind of hemolysis. And it includes a group D, which is Enterococci, and our Streptococci, that is Streptococci bovis. So what do you see here is the group A, B, D, and all that. It is something called the Landsfield classification, which is based on the antigenic characteristic of the C carbohydrate that is there on the cell wall polysaccharide. Okay, there are so many other classifications also, but the most prominent one we have shown you here. And just to show you now, this once you know it is partial hemolysis based on the optotion sensitivity. If it is sensitive, it goes to Streptococcus pneumoniae, and if it is not, if it is resistant, it goes under Viridans. Similarly, for bacitracin, group A will be sensitive, group B will be resistant. And similarly, for the gamma hemolytic, there's no hemolysis, it can be distinguished between 6.5% sodium chloride. Now, how does it appear on the plate? So if you can see on the left, it is the alpha hemolysis, and that is partially, the blood is lysed. But in beta hemolysis, you can see there is clear, transparent, fully hemolysis. You can watch there. And when it comes to gamma, there is no hemolysis. Now, coming to the alpha, what are the differences? There are two major ones: strep pneumoniae, which is sometimes called as the pneumococcus, and the Viridans group Streptococci. So both are cocci, gram-positive cocci, but Streptococcus usually comes in pairs, but Viridans are usually in long chains. And Streptococci is like a lanceolate shape, towards the edge, it is curved, but Viridans, it's kind of round or oval. And Streptococci has a capsule, and that is the most virulent thing that Streptococcus pneumoniae has, something that we need to look about. And it is soluble in bile when it comes to Streptococcus pneumoniae. And like I said, optotion is sensitive when it comes to pneumonia, and Viridans, it is resistant. Now, going in depth regarding the Streptococcus pneumoniae, we know that it is catalase negative. It grows in pairs. It's usually diplococci. Two of them usually attached, or sometimes you also see them as a chain. But it's usually two cocci attached to each other, which gives you the diplococci look. And the thing is that it does not. The alpha group does not have Landsfield classification. That means that antigen of that C carbohydrate is not there. Therefore, it doesn't come under the Landsfield classification. It is also known as pneumococcus. This is something that should not confuse you. Streptococcus pneumonia is pneumococcus. Okay. So whenever you hear pneumococcal vaccine, it's always about Streptococcus pneumonia. And it is a normal flora of the upper respiratory tract infection. And there are so many virulence factors that contribute to the disease activity of this organism. The major one is, like I said, is the capsule, the polysaccharide capsule. What it does is that this capsule avoids phagocytosis or opsonization. Therefore, it is easy for this organism to cause diseases. The other ones are the adherence protein, biofilm production, pnemolysin toxin. These are pyogenic in nature, that means it produces pus, and more than 90% serotypes of streptococci pneumoniae are there. Okay, so coming to the clinical spectrum, streptococci pneumoniae, you just need to think of 4 infections. It mainly causes 4 infections that are very clinically relevant and prevalent. The first one, like you would suggest or you would think, would be the community acquired pneumonia, because it is the commensal of your respiratory tract. It can go and invade your lung and causes infection in the lung parenchyma. Now, this is called, this usually causes lobar pneumonia. I would like to tell you the difference between lobar pneumonia and the atypical pneumonia. Lobar pneumonia is the typical pneumonia where you see a consolidation. Okay, so what happens is that in lobar pneumonia, like it is usually caused by Streptococcus pneumoniae, Haemophilus influenzae, and gram-negative, gram-negative bacteria. There will be productive cough because it goes into the alveoli, causes all the damage, and causes this this consolidation, or this consolidation that you see on the X-ray. But when it comes to the atypical pneumonia, which is usually caused by your atypical organisms like Moraxella, Mycoplasma, Legionella, and Chlamydia, it goes into the interstitial spaces, not into the alveoli. So, in between the alveoli, it goes and does the damage. Therefore, you do not have that productive cough where the sputum doesn't come out. So the interstitial pneumonia, it's usually like a lot of haziness in the lobes. It is not like a consolidation as such that you will be able to see. Now, first I told you it's a pneumonia. It's usually the community acquired pneumonia. The next 2 ones, which is very common in children, is otitis media and sinusitis. And the last one is the meningitis, which is prevalent in both adults and in children. So these are the 4 infections that you need to know about Streptococcus pneumoniae. So whenever a patient comes with any of these infections, Streptococcus should always be on your list of the most prevalent organism that can cause the infection. Now, 60% of the meningitis cases are attributed to Streptococcus pneumoniae or the pneumococci. And the complications include endocarditis, empyema, bacteremia, and sepsis. Coming to the spectrum, here you can see that in all this chart where all the organisms are kept, Streptococci must be the one that has the most number of antibiotics that are sensitive to it. The most number of classes that are sensitive to an organism would be Streptococci. So you can see penicillins, from penicillins, all the beta-lactams, to your levofloxacins, your colistin, your clinda, again, the top gram-positive, like Vanco, linezolid, everything is usually sensitive to Streptococci. Now, when do you pick up a pneumococcus? So when you send a culture, it has to be good quality sputum. What do you mean by good quality sputum? That means that the number of epithelial cells that are reported in the sputum must be very less when compared to the neutrophil or the pus cells that are being reported. Okay, that is less than 1 epithelial cell per 10 to 20 neutrophils. So if you see a culture where it shows epithelial cells numerous, pus cells few, it means most likely it is saliva. It is not a good sample. So if you have a good sample, and if you see diplococci, it is more indicative that it is a true infection in a patient with a clinical setting that is similar to pneumonia. Now, the treatment of choice for Streptococcus pneumonia has been penicillin for a very long time. And the other ones that are being used are your your beta-lactams like amoxicillin, your 3rd generation cephalosporins. Now, what you need to look out is that when it comes to pneumonia, even if your MICs are high, because beta-lactams has the capacity to go and concentrate in your lung, there are very less chances that it causes failure in treatment. Because, like I said, because of so if you have like a borderline or intermediate resistant one, giving higher concentration might help in overcoming the MIC. This has to be taken with a pinch of salt because you don't want to end up in treatment failure, but this is something that we can target for. Now, if you have blood cultures that are positive for pneumococcus, based on the resolution of your pneumonia, the duration of treatment is just 5 to 7 days, even if you have blood positive for pneumococci. So it doesn't, that means if the lung is getting better, you don't have to give for 10 days or 14 days. Shorter days of therapy is available. The other thing that I would like all of you to go and look is the CLSI breakpoints for CNS and non-CNS isolates, because this is very, very important. If it is a patient that is coming with meningitis, the MIC or the CLSI, as per the CSLI guidelines, is much lower in the CNS isolates that needs to be reported versus the non-CNS isolates. So that is something that you might have to cross-check with your microbiology to see if what you're writing as penicillin sensitive is actually as per the CLSI guidelines. Now, for IV penicillin, the CNS isolate MIC should be less than 0.06. And for non-CNS isolates, it should be less than 2. Now, the oral beta-lactam activities against pneumococcus are as follows. Penicillin is equal to amoxicillin. So penicillin and amoxicillin therefore are used interchangeably. That is one major reason why you see amoxicillin being used in the community for a lot of children, a lot of adults, because usually it is streptococci that is causing your respiratory tract infection, and followed by cefpodoxin, and cefuroxime and cefixime, not so much. Now, what the problem for us is the drug resistance that is being seen with pneumococcus. Ever since penicillin was introduced, penicillin resistant strep pneumonia has come up. And as you can see in this figure, as and when each new drug that is sensitive to this organism has been identified, resistance has followed the organism. And right now, we even have cases of multi-drug resistant strep pneumonia. Now, what we need to know about this one is that the mechanism for this drug resistant is because of the rearrangement in the target binding site. It is not beta-lactamases like your gram-negative, gram-negative organisms, or maybe in the Staphylococcus also we saw that, some of them produces beta-lactamases. But pneumococcus, it's usually the alteration in the target binding site, the alteration in the penicillin protein binding sites, thereby reducing the affinity towards the drug going and binding your organism. So the strains that are associated with high-level amoxicillin resistance, that is MICs of 4 to 8, are usually because of the alteration in the penicillin binding protein 2B. Macrolide resistant, there are 2 genes, that is ERMB and MEFA. ERMB and MEFA. ERMB is also because you know that macrolides usually go and bind to the 50S subunit. It causes alteration there. Therefore, the affinity for the macrolide to go and bind to the organism is reduced. And MEFA is an efflux pump. It pushes out the drug from the organism's cell. Fluoroquinolone resistance is usually because of the spontaneous mutation that happens to the target, that is topoisomerase 4, or otherwise called as a DNA gyrase. Now, how do you treat or this penicillin-resistant Streptococcus pneumoniae is something that has been very worrisome for the Western world and for us also. The actual choices include, the third generation cephalosporin like ceftriaxone and cefotaxime. Now, you have to, again, the pearl that I would like to give is that if your MIC for ceftriaxone is 4, you should use 2 grams per day of ceftriaxone rather than 1 gram only. So when it comes to cap, sometimes we treat with 1 gram only, but if your MIC is high, you need to give 2 grams. Now, there are certain drugs you would like to avoid, which is cefuroxime and ceftazidime, because there are data that suggests that it causes treatment failure when you treat penicillin-resistant strep pneumoniae. Now, the ceftazidime is as per the Grayson et al., which was published in 2018. Cefuroxime, there are a lot of literature that does indicate treatment failure. So we must always see that a patient who comes to the hospital treated with ceftriaxone, 3-4 days the patient is looking okay, you want to discharge the patient. So it's always an oral antibiotic that you look forward to, right? So try not to give cefuroxime for these patients. Maybe cefuroxime is another choice that you can try, but cefuroxime and ceftazidime may not be the best choices to give if you are having penicillin-resistant strep pneumonia. Now, if you have MDR strep pneumonia, you can use high-dose levofloxacin. The usual dose of levofloxacin for CAP is 500 mg, but the 750 mg is usually the pseudomonal dose of levofloxacin. But if MIC of levofloxacin is quite high, you use 750 instead of 500. The other one obviously is vancomycin, but if your organism, if your pneumococcus is cephalosporin resistant, you should not use vancomycin as a single agent to treat meningitis or endocarditis. These are the clinical pearls that you can easily do as part of your antimicrobial stewardship. This slide has a lot of information that can help you with your clinical practice. And obviously, linezolid. Now, RH is a 56-year-old male with a history of diabetes type 1 and COPD with multiple hospitalization because of the acute exacerbation. Now he's coming to the outpatient setting for the annual routine physical examination. Which of the following vaccines should be offered to him at this time in aiding the acute exacerbation of COPD episodes? Which one would you choose? Annual influenza, the pneumococcal conjugate vaccine 13, the pneumococcal polysaccharide vaccine 23, or the pneumococcal conjugate vaccine 7. So like you can see, I'm going towards the pneumococcal vaccine. So among the, okay, let's forget about the influenza. Influenza is something that we should offer, but the more data is suggestive, and it is saying that patients with acute exacerbation of COPD, the pneumococcal vaccine is more important than the influenza vaccine, because data do suggest that it has so much more benefit in administering the pneumococcal vaccine. Now the question is, among B, C, D, which one would you give? Kindly, if possible, write down the answer so that it becomes easy for you. The correct answer for this one is actually B, which is the conjugate vaccine 13, because the patient is less than 65 years old, and at this time the patient should get PCV 13 rather than PPSV 23. Now coming to vaccines. If you can see in that figure, there is a diplococci, two streptococci pneumoniae just holding on to each other, and there is something surrounding it, the red beads that are surrounding it, which are the capsule. And I told you capsule is the most antigenic thing that causes a lot of trouble to us, because it's difficult to get rid of this organism because of the capsule it has. But what we have found is that we have found vaccine towards this using this capsule. Now this polysaccharide, this beaded thing that you see there are nearly 92 subtypes that are there, and it is expressed on the cell surface, cell wall surface. Now, like I said, it protects this organism from opsonization, from destroying the organism by opsonization. Therefore, making it this target antigen, this polysaccharide layer, the target antigen, and this capsule, the capsule polysaccharide is very immunogenic. So what is being out of the 92 subtypes that we see, globally, 6 and 19F are the most reported serotypes. And in India, additionally to 6 and 19F, we have 1 and 19A that are being reported when it comes to Streptococcus. Now, what we have done is to have vaccines against the Streptococcus pneumonia. There are 2 vaccines that you can see. One is a polysaccharide vaccine, that is PSV, the pneumococcal polysaccharide vaccine. The other one is pneumococcal conjugate vaccine. Now, initially, in 1945, the first vaccine against strep pneumonia was developed, but it had only 4 subtypes. It covered only 4 subtypes. Then, in 1970, from this 4 subtypes, they increased to 14 subtypes. And in 1983, that is from 17 to 1983, our PPSV came. So the first vaccine that came was this PPSV. So it is nothing but the capsule polysaccharide. So pneumococcal polysaccharide vaccine. It has good efficiency. But the problem with PPSV was that the most eligible population that has a high burden of disease because of pneumococci is children below 2 years. Okay, because children below 2 years are unable to produce antibodies against this vaccine, this became in a way a failure, but it still has good activity against adults. Okay, so to give it more antigenic properties so that our immune systems are hyped up, we conjugated it with the diphtheria toxin. So the conjugate with the diphtheria toxin and some of the polysaccharide is the PCV. Okay, initially PCV7 was introduced in 2002, and later PCV13 was introduced. Okay, and this PCV is something that you give as routine vaccination for children less than 2 years, because the meningitis, the pneumonia, the sinusitis, the otitis media, all 4 infections are very prevalent because of pneumococcus in this age group. That is why we needed this vaccine. Now, to have a comparison regarding PCV13 and PPSV23, the brand name that we commonly say is Prevnar for conjugate vaccine. And when it comes to the polysaccharide vaccine, it is the Pneumovax. And you can see the number of subtypes and the subtypes that are included in these vaccines. Now, the age group, like I said, the PCV is more for children, infants, but also for people who are elderly and who are high-risk patients. Okay, and immunological response is because the reason why PPSV did not act well was because it was T-cell independent. It was usually by the humoral response by B cells, and which is not very good in children. But the PCV, the conjugate vaccine, it is T-cell dependent, and therefore it can provide prolonged immunity. Now, the efficacy is almost 70% for both. PCV, the good thing is that it promotes herd immunity. So if a lot of children, are getting this on a universal basis, it is very possible that we can get rid of pneumococcal infections to a very large extent. But this herd immunity is not provided when it comes to the PPSV vaccine. Okay. Now, how do you give it? What are the schedules? As clinical pharmacists, we must know when you give vaccines to children and adults. Okay. For children, it is nothing but 3 doses of PCV13 at 6 weeks, 14 weeks, and after completing 9 months. That is the booster. And it's a 0.5 ml injected into the mid-thigh, which is an IM injection. Now, when it comes to adults, there are categories of adults that are eligible to take. Anyone can take vaccine, but the active group that we would want them to take are the people with chronic comorbid conditions like all your lung, heart, liver, diabetes, smoking, alcoholism, long-term care facility resident, all these under the comorbid, and those who are immunocompromised, those who do not have a spleen, those who are having a CSF cochlear implant, people who are immunosuppressed, who have done an organ transplant, etc., cancer, chemotherapy, all these are the patients who are at immunocompromised or high risk. Now, based on that, I'm only going to tell you what the patient needs to take if they have not taken it before. Okay, for vaccine naive adults. Okay, so adults who are more than 65 years without comorbidities. Okay, so anyone who is above 65 should get the PCV 13 first, and after 1 year should get PPSV 23. Now, the adults who are less than 65, the same one again as of those who are above 65. But the only difference is that once they cross 65 years, if it is more than 5 years since the last dose, like the patient we just discussed, the patient is 56 years old, who is the case that we saw now. So once he goes on to 65 years, that's when he needs to get the booster dose with the PPSV. Now, immunocompromised patients, what you need to look out for is this gap. The PCV always comes first, but after 8 weeks, they should also receive the polysaccharide vaccine. Okay, and every 5 years, get additional polysaccharide vaccine. This is how you give pneumococcal vaccines to adults. Sorry. So that covers pneumococcus. Now coming to Viridans streptococci, which again is the alpha hemolytic organisms. Viridans streptococci, they, as you can see, it is also like chains. It is gram-positive. In pairs and chains, it is a facultative anaerobic. It is non-motile, non-spore forming. They are usually seen in your mouth. Okay, so just get that they are seen in your mouth and in your upper respiratory tract. Sorry. So, like I said, they are commensals of the upper respiratory tract and of your mouth, but they do not usually cause infection, but they can. Thing is, the most common, there are so many, subspecies of Viridans streptococci, and what actually happens is that streptococci anginosus are the most virulent, and they can cause pyogenic, like the abscesses, your mouth, whatever abscesses that are occurring, it can be because of this group of organism. The other thing that you need to know about them is that how do you treat penicillin-resistant isolates? Simple ways to give a higher dose of beta-lactam antibiotic. It overcomes resistance. Also, adding a low dose aminoglycoside to the beta-lactam results in synergy, and there is faster clearance of infection. Okay, and more non-beta-lactam agents are vancomycin, quinolones. Okay, now what are the common problems that these organisms cause? One is a subacute bacterial endocarditis, which causes 20% of infective endocarditis. Okay, subacute bacterial infective endocarditis is something that it causes. Dental caries, as I said, it is in the mouth, and prolonged bacteremia in neutropenic cancer patients. So what happens is that if the patient is neutropenic, if the patient has whenever they brush or whenever they do, because of the transient small breaks in the skin that happens with all these things, it can go inside and just stay there forever and ever. Therefore, prolonged bacteremia is something that it can cause, not necessarily don't. Okay, and like I said, these are the first line and the second line agents that you choose to fight this bacteria. So that is the alpha hemolytic bacteria. Now coming to the beta hemolytic bacteria. Our first one is group A Streptococcus, sometimes called as gas, sometimes called as Streptococcus pyogenes. Now, you can see here your Streptococcus pyogenes. So they are also cocci in chairs or paints, facultative anaerobe. Thing is, if you do not treat it at the right time, it can rapidly progress. Okay, it has a lot of virulence factors. And the most common virulent factor, the two major causes are, one is this hyaluronic acid capsule. Okay, so whenever you have hyaluronic acid, it helps you to go through from tissue to tissue. It is invasiveness. With hyaluronic acid, you have invasiveness and it resists phagocytosis. Okay, it helps in spreading the infection. The other major problem is this organism. Pyogenes have M protein. Okay, and it is considered to be the principal virulence factor, and it is also an antigenic determinant that prevents obscuration. Now, what happens in this? We've heard that rheumatic fever. Rheumatic fever is nothing but group A streptococci infection, the same organism, Streptococcus pyogenes. So, what happens in rheumatic fever? So, this protein M, it is antigen. It's an antigen, right? Protein M is an antigen, and against this antigen, there are antibodies that are being produced. But the problem is that these our heart muscles, our cardiac muscles have something that is very similar to this M protein. Okay, so these antibodies that are produced against Streptococcus pyogenes, because it's similar to our heart, this heart muscle, the heart, they go and destroy our heart muscles and makes it weak and causes rheumatic fever. Okay, therefore, that is how you usually get rheumatic fever. You have various toxins that this organism causes. The hemolysin, you must have heard of ASO, the anti-streptolysin O, which is in a way done to see retrospectively to see if the patient had any kind of streptococcal infection, it's group A streptococcal infection before that has contributed to certain heart related problems and things like that is something. So ASO, and the other one is something called the streptococcal pyrogenic exotoxin. This is one toxin. That is why there is scarlet fever. Scarlet fever is where the malar area of your face and everywhere, it becomes bright red, brick red, because of this streptococcus. Because of this toxin, that scarlet fever is the reason why scarlet fever occurs. And it has a lot of enzymes, which is the streptococcus and streptokinase and streptodornase. So streptokinase, we know it is used for the fibrin destruction so that clot doesn't happen. So and the streptodornase is something that is against the DNA. Okay, so it helps in breaking down the DNA and it helps in liquefying the thick pus. Okay, so these are the two enzymes that this organism possesses. Coming to the clinical spectrum, the first one that we all know is the strep throat, where you have the red swollen tonsils, the pharynx, purulent exudate, high temperature, swollen lymph nodes all over here. So this is basically nothing but the strep throat. Then skin and soft tissue infection, it can range from simple folliculitis to impetigo cellulitis. But the major problem that we have is when this cellulitis goes into necrotizing fasciitis. Now, like I said, M protein is something that is the most, the virulent factor for Streptococcus pyogenes. So because of this M proteins, since they block this phagocytosis, they move rapidly through the tissue and along the fascia. Okay, so between the subcutaneous tissue and the muscle, they quickly go through the fascia, and within 1 day of the infection, the patient start to have the symptoms of cellulitis, the redness, swelling, and warmth. Okay, but then one more day later, the skin color changes from red to purple, then to blue, and big bullae are formed. Once the bullae are there, you know it is bad. You have to treat it very severely and urgently. Address that infection very urgently, because late therapy with antibiotics can cause severe damage, and in such cases, it is best to give some protein synthesis inhibitors. Okay, the two major protein synthesis inhibitors that we use are clindamycin or linezolid. That's why you see surgeons, whenever patient has cellulitis or necrotizing fasciitis, they always use a clinda or linezolid. Now, the thing is that if you're using clinda, you don't have to use linezolid, because some doctors write linezolid, but to avoid the toxins, they write clinda, because both of these drugs can reduce a toxin production, and therefore it is equally beneficial. The other one, like I said, is a scarlet fever. Scarlet fever, like I said, because of the pyrogenic toxin, from the trunk to the neck and spread to the extremities, and sometimes sometimes it can cause this reddish, this thing of the face also. Okay. And toxic shock syndrome, because of the toxins that it produces. Two other clinical syndromes I would call is the post-infection sequel. That is, once the infection has come and gone, it can create two major problems. One, as I told you, is the rheumatic fever, where where the Streptococcus pyogenes M proteins, the antibodies that are produced against these M proteins, goes and damages your heart because it cross-reacts. It causes myocarditis, and that is how the rheumatic fever comes. And then rheumatic fever, can go on into rheumatic heart disease. Okay. The other one is the acute post-streptococcal glomerulonephritis. This is especially seen in children. After 3 days to 1 week of having a streptococcal infection, what happens is that the antibody and antigen antibody complex that are formed will go and get stuck in the kidney, and there it produces a lot of reaction, inflammation, and a lot of damage, causing glomerular destruction of the kidney, which is called as the acute post-streptococcal glomerulonephritis. So, to summarize, it can range from simple skin infections, the pharyngitis, the strep throat, to otitis media, and it can go on to give you scarlet fever and post-infectious sequelae like rheumatic fever going on into rheumatic heart disease and the acute post-streptococcal acute glomerulonephritis. Now, the pharmacotherapy, always penicillin is the drug of choice. Unlike pneumococcus, resistance towards penicillin is very low when it comes to pyogenes, and you can have second-line agents if needed. Okay, that is regarding the group A Streptococcus. Now coming to group B Streptococcus, which is again beta hemolytic. That means it causes complete destruction. The one and only thing that you need to know is the Streptococcus agalactiaceae. So the easy way I remember is group B, B for babies. Okay, B for babies, because it usually causes neonatal sepsis. It is one of the major causes for neonatal sepsis. It is also a gram-positive diplococci, which causes mucoid colonies. Like you can see here, it is like mucus. So it causes mucoid colonies. Now, this organism is present in the female genital area and in the lower GI tract towards the rectum. But it is an asymptomatic colonization. It is just there, not causing any problem. And up to 40% of females are actually colonized because of with this organism. Problem is during pregnancy, when the patient is in labor, when the pregnant mother is in labor, there will be skin break, and due to the skin break, this can go and cause various kinds of infections, both to the mother and to the baby. Now, there is vertical transmission also. That is, from this asymptomatic colonization, it can go and infect the child and can cause neonatal septicemia, pneumonia, and meningitis. All of them are with very high mortality rates. Okay. In non-pregnant adults, if the patient is immunocompromised, it can cause all the usual infections like bacteremia, pneumonia, endocarditis, skin and soft tissue, arthritis, meningitis. Okay. Now, how do we treat it? Again, same as group A. So, for both hemolytic, beta hemolytic, the pharmacotherapy is almost similar. It is usually penicillin. Only thing that you need to know here is that whenever a female is getting pregnant, you look for this group B colonization, because if there is colonization, you need to prevent this vertical transmission and prevent this this organism causing injury to the child. And if the child is affected with meningitis, ampicillin plus gentamicin is your drug of choice. Okay, now coming to Streptococcus. Streptococcus bovis, which is the group D. Now, like I said, group D comes under gamma, which is no hemolysis. Group D also includes enterococci, but enterococci is no longer included in this classification. It is being considered into a separate classification. Okay. One thing you need to know about this Streptococcus bovi. Sorry, that picture is wrong. That picture is as of the Agalactaceae. It is not bovis. So the subtype is known as the Galolyticus. The most common infections the bovis can cause is again infective endocarditis, bacteremia, and what is the one organism that I told you that can cause subacute endocarditis? It is Viridans group Streptococci. So this mimics Viridans group Streptococci and therefore can be misidentified as group D Enterococci or Viridans group Streptococci. And one thing you need to know about this bug is that if you isolate Streptococcus bovis or Streptococcus galolyticus, the subspecies, it is associated with high risk of malignancy, colon cancer. So whenever you have a patient who has a bacteremia with Streptococcus bovis, always look for colon cancer, okay, which includes a colonoscopy and a CT scan to see if there are any kind of cancer that is going on in that patient, because 50% of the patient have some kind of association. Okay, and the pharmacotherapy with which or the drugs we use is similar to the previous one, penicillin with gentamicin. Now, coming to enterococci. Now, enterococci again is one major classification and one of our major common bug that we see in our clinical practice. They are also in chains, formerly known as the group D streptococci. They are non-hemolytic. Two major species are there. This is again something you need to know. E. faecalis, Enterococcus faecalis, and faecium. Faecium is common but is less resistant. Faecium is less common but is more resistant. So whenever you have a report that says Enterococcus species, and if you're resistant to most of the drug, it's most likely it is faecium, and it is usually hospital acquired. Now, enterococci. Entero is gut. Okay. So where does it stay? It stays in your GIT. So whenever your gastrosurgeon goes and digs the bowel or do some procedure, this is one organism that they are scared about. So they always give a gram-positive coverage. And this has been associated with a lot of nosocomial infections, which includes bloodstream infection, infective endocarditis, urinary tract infection, wound infection, intraabdominal infection. This urinary tract infection, this is one of the major pathogens because, from your rectum through your anal canal, because this bacteria is there, it can easily go and infect your urinary tract. Now, there is one other question that I would like to ask you. Enterococci are intrinsically resistant to which all antibiotics? Is it cephalosporin? Is it clindamycin? Is it Septran, which is cotrimoxazole or sulfamethoxazole trimethoprim? All of the above or only clindamycin and Septran? Kindly note down your answer. Let's see how many you will get it right. One thing you need to know about Enterococci among all other gram positives is that it is intrinsically resistant to all cephalosporins. So the answer is all of the above. It is resistant to cephalosporin, Clinda, and Septran. Now, unlike staph or strep, they do not produce toxins, but they have other things like the capsule and pili and all these things that helps them move around and all that. And they have the ability to form biofilms. Okay. And therefore, it is once you have a biofilm, it is difficult to go and penetrate that biofilm. Now, the pharmacotherapy usually always the drug of choice for Enterococci is ampicillin. This is something you should have in your mind. And if it's a serious infection like endocarditis, you give it along with an aminoglycoside. The other choices are mentioned here. Even carbapenems are sensitive to fecalis, not faecium. Faecium is usually, it is like, more, or I would say worse than MRSA. Faecium is always resistant. And usually all these drugs don't work except for the vancomycin and daptom. And the newer drugs that are, currently being studied against Enterococci are telavancin, oritavancin, and dalbavancin. Like I said, this organism causes a lot of urinary tract infection. And if it's only an uncomplicated cystitis, nitrofurantoin works and fosfomycin also works for Enterococci. But note that it is intrinsically resistant. Whether it is fecalis or faecium, it is intrinsically resistant to cephalosporin, clindamycin, aminoglycoside, and trimethoprim sulfamethoxazole. Now, you would think that I have mentioned aminoglycoside as intrinsically resistant here, but in the drug of choice, I have given ampicillin plus aminoglycoside. Why do you think I have done that? It's usually whenever you give a beta-lactam, you destroyed the outer cell wall, right? It goes and binds to the cell wall and destroys it. Once, because the aminoglycosides are unable to go inside because of the cell wall, and because the cell wall is modified, it is easy for the aminoglycosides to go and, inhibit protein synthesis. That's why there is synergy between all these gram-positive organisms with aminoglycoside. If you give it as monotherapy, it will never work because it cannot enter. For all aminoglycosides are purely gram-negative. But if you give it with a beta-lactam, that's when you can have this kind of action. Now, the other thing that I want all of you to keep in mind is that if you have infective endocarditis because of Enterococci, you might see double beta-lactam strategy. That means when you have, usually we say that for whatever infection, you don't give two antibiotics from the same class. Okay. It's not just two antibiotics from the same class, but it is for enterococcal endocarditis, the IDSA has suggested ampicillin plus cephalosporin. Cephalosporin, even though it is intrinsically resistant, double beta-lactam with ampicillin and cephalosporin is one strategy that we use to treat infective endocarditis. Now, for a fresher like me, when I used to go for rounds, I used to think, how can you give a cephalosporin to a person with Enterococcus? Because it's intrinsically resistant. It's intrinsically resistant to that organism. This is where the guidelines come into role, and this is where you need to look up before you judge the treatment decision. Okay, so if you know the guidelines, you cannot go wrong. Now, if you see the Enterococci, very little amount of drugs that you can give. The ones that you can give are towards the end, the small ones that you can give. So the VRE, the vancomycin resistant enterococci, which is usually the Enterococcus faecium, nearly 10% is being reported, and out of it, 17.4% is the Enterococcus faecium. And the resistant mechanism is something called as the VAN-A gene. What happens is that this gene will modify the binding site of vancomycin, which is DADA, the D-alanine terminal into DADL. Okay, so alanine is converted to lactate, and therefore vancomycin does not have much affinity. And how do you treat? These are the drugs that you can use to treat VRE. Daptomycin is one of the best choices that you have currently. Linezolid also. TG-cycline should be your last resort. TG-cycline, even though sensitive for VRE. If it is an endocarditis, if it's a bacteremia, you know that TG-cycline does not stay in your blood. No insufficient blood concentration is achieved for TG-cycline. So wherever possible, do not use TG-cycline for bloodstream infections. So key takeaways are streptococcal species are classified based on the type of hemolysis and the large scale class. Streptococcus pneumoniae is a major contributor for community-acquired pneumonia. The other three are meningitis, otitis media, and sinusitis. There is increasing drug resistance, and vaccination is the key. You always give PCV13 first, then you give PPSV23. Viridans streptococcus usually associated with subacute endocarditis. Group A streptococci, lot of diseases it can cause. Penicillin is a drug of choice. Group B streptococcus, B for baby, meningitis in babies, neonatal sepsis, need for screening mothers during pregnancy. Whenever you have streptococcus bovis bacteremia, it is associated with higher risk of colon cancer. And enterococcal infections, the nosocomial rates of these infections are rising, and the resistant rates are also rising, which is especially VRE. So once you have an infection like VRE, your cost of treatment also goes up. So these are the key takeaways for you from this presentation. Thank you. If you have any question, you can put it in the chat box.
Yeah, ma'am, we have a couple of questions.
Yeah.
First one, could you please focus on the penicillin resistant rate in streptococci and why resistant rates are very rare?
So I didn't get the question.
Okay, I'll repeat. They have asked, could you please focus on the penicillin resistance rate in streptococci and why the resistant rates is very less?
That question, see, streptococci, all these classes are there. Which one are they talking about? Are they talking about group A or group B, or is it because pneumococci bacillus resistance is high? So if you're asking about group A or B, penicillin, even crystalline penicillin is something that I use. I see my surgeons still using. See, I think the resistance against group A and B is lower because of what? Is that the question? I think that's the question. That I'll have to see, and that I'll have to check why it has not. See, it's easier to find out why something has happened rather than find out why something has not happened. Yeah. So I'll have to check that why it has not happened.
Yeah, one more question, ma'am. Can you list out the contraindications of PCV13?
I didn't get you.
Contraindications of PCV13.
Contraindications of PCV13. See, one thing is that when you give other vaccines, the other vaccines that you're using against for various other infections, that is, you need to give that gap between the 2 weeks, or that 2 weeks gap is one thing. And if you are having one contraindication that always comes up is because these are, the polysaccharide conjugate and all these things. One thing is regarding the sensitivity, the allergic reaction that happens to the PCV. And I think the other one for PCV 13 would be this one, an active infection. If a patient is having an active infection, you should not give, you should wait for the active infection to subside.
I think that's it. If you have any more questions, please mail it at fcpaofficials@gmail.com. And the feedback form will be made available below the video thumbnail in the website. Thank you, ma'am. I can't believe you took this entire session when you're this ill.
No problem. All right. Okay. Thank you.
Thank you.